If you've been told you need to choose between treating your Crohn's and having a baby, I need you to hear this. That's not actually the choice in front of you. Hi, I'm Kate, and today we're talking about fertility and pregnancy planning when you have Crohn's disease. This matters right now because too many people are stopping medications out of fear, making themselves sicker and actually reducing their chances of a healthy pregnancy. When my son was diagnosed, one of his first questions wasn't about food or symptoms. It was, will I be able to have kids one day? And that was because after surgery early on, my husband had been told the possibility of children was not that great. And I've sat across from so many women in my practice who are terrified. They're in remission, on a biologic, and feeling great for the first time in years. And they've been told by well-meaning family members or reading things online that say they need to stop everything before trying to conceive. Some have already stopped their meds without telling their doctor. They're flaring, they're scared, and they're stuck between two fears: the fear of what the medication might do, and the fear of what active disease definitely will do. I get it. When it's your body and your future baby, every decision feels enormous. Here's what most people get wrong. They think the question is, are these medications safe during pregnancy? But the real question is, what's safer for both me and my baby? Controlled disease on medication or active inflammation off medication? And the research is really clear on this. Active Crohn's disease during pregnancy increases the risks of preterm birth, low birth weight, miscarriage, and complications for both mum and baby. Those risks are significantly higher than the risks associated with most Crohn's medication. The other thing people get wrong is thinking this is just about medication safety. It's not. It's about planning. It's about timing. It's about getting into the best possible remission before you conceive and having a care team that communicates with each other. Most GIs don't have time in a 15-minute appointment to walk through all of this, but these are the conversations that need to happen before you start trying. So, let's walk through what you actually need to know. I'm going to cover medication safety first. Then we'll talk about the planning piece that matters just as much. What the research says about specific medication is this. Let's start with biologics. Drugs like Remicade, Humira, Stelara, and Entyvio. These are the medications people worry about most. And here's what we know. They're considered compatible with pregnancy. The research shows that women on biologics who are in remission have similar pregnancy outcomes to healthy women without IBD. The American Gastro Association, the British Society of Gastroenterology, and Crohn's and Colitis Australia all say the same thing. Continue biologics during pregnancy. Now, some biologics do cross the placenta, especially in the third trimester. That's why some doctors adjust timing or dosing in late pregnancy, but stopping them completely, that usually causes more harm than good. Immunosuppressants, these are also considered compatible with pregnancy. There was older data that made people nervous, but the larger, more recent studies show immunosuppressants don't increase the risk of birth defects when used at standard Crohn's doses. Steroids like prednisone, they're safe for short-term use during pregnancy if you need them to manage a flare. They don't cross the placenta as much as other steroids, so if you need them, you need them. But obviously the goal is to not be dependent on steroids going into pregnancy. The one medication that is not safe during pregnancy, guess what it is? Methotrexate. If you're on methotrexate, you need to stop it at least 3 months before trying to conceive. And you need to be on reliable contraception until then. This one's a non-negotiable. The conversation about disease activity matters more than the medication list. And here's what I want you to understand. Being in remission when you conceive is the single most important factor for a healthy pregnancy outcome, not which medication you're on, whether your disease is controlled. In my practice, I've seen women get so focused on the medication question that they lose sight of this. They stop their biologic because they're scared. They flare 3 months later, and now they're trying to conceive with active inflammation. That's a worst possible scenario. Active disease during pregnancy increases the risk of everything you don't want: preterm delivery, low birth weight, C-section complications, and if you flare during pregnancy, your treatment options become more limited. So what's the goal? The goal is to get into the deepest remission possible before you start trying, and that usually means staying on your medication. So what does remission actually mean in this context? Well, when your GI says you're in remission, ask them to be specific. Do they mean clinical remission? Your symptoms are controlled. Or do they mean deep remission? Your inflammatory markers are normal and your scopes show healed tissue. For pregnancy planning, you want deep remission. You want your CRP normal, your fecal tail protected low, and ideally, you want recent scope results showing mucosal healing. This is a conversation to have with your GI before you start trying, not when you're already pregnant and trying to figure out if it's safe to continue your medication. So the question to ask your care team before trying to conceive is, well, firstly, you need 3 people talking to each other: your gastro, your obstetrician or midwife, and ideally a maternal fetal medicine specialist if you're considered a higher risk. And here are the questions to ask your GI. Am I in deep remission right now? What are my most recent inflammatory markers and scope results? Should I continue my current medication during pregnancy, or will we adjust it, timing or dosing? What's the plan if I flare? What medications are safe at that point? And how often will we monitor my disease activity during pregnancy? And here are the questions to ask your obstetrician. Have you worked with pregnant women with Crohn's before? Will I need additional monitoring or scans because of my IBD? Are there any specific pregnancy complications I'm at higher risk for? Who do I call if I'm having symptoms and I'm not sure if it's Crohn's or pregnancy related? The next thing to consider is naturopathic support. It's a piece that will actually help. So this is where I come in, and it's not about replacing your medication. It's about optimizing everything else so you're going into pregnancy as strong and nourished as possible. That means checking iron, your B12, your vitamin D, your folate. Women with Crohn's are often deficient in one or more of these, and they will matter for fertility and pregnancy outcomes. It means looking at your diet and making sure you're getting enough protein, enough calories, enough omega-3s. If you've been restricting foods to manage symptoms, we need to work on gently expanding your diet so you're not going into pregnancy already depleted. And it means managing stress and sleep because both of these affect disease activity. If you're flaring from stress, that needs to be addressed before you conceive. This is a supportive care that sits alongside your medical treatment. It's not either or, it's actually both. When I was pregnant with my second son, I had to have a C-section. It really was stressing me out because I had a home birth for my first. I spoke to a friend who was an Ayurvedic doctor, and he said, "What are you worrying about? Just have the most natural C-section that you can," which kind of didn't make sense until I thought about it. So basically what he was saying, get your body into the healthiest place it can be, and then have the C-section. So let's come back to where we started. The choice in front of you isn't between treating your Crohn's and having a baby. The choice is between going into pregnancy with controlled disease and a clear plan, or going into pregnancy with active inflammation and just hoping for the best. I've watched my son grow into a young man who knows he can have a family one day if he chooses. I've worked with women who've had healthy pregnancies while staying on their biologics, and I've seen what happens when someone stops their medication out of fear and actually just ends up sicker. So, you can have both. You can treat your Crohn's and have a healthy pregnancy. But it takes planning, it takes the right care team, and it takes staying in remission. If this helped, share it with someone who needs to hear it. And if you're in the planning stages and you want support, the nutrition, the deficiencies, the stress piece, that's exactly what I do. You can find me through the Crohn's Method community or reach out about one-on-one coaching. Have a beautiful day, and I'll see you in the next video.